Good evening, everybody. Thanks for joining in. My name is Ruben Manohara. I'm an orthopedic surgeon from Singapore. I'm in private practice and I'm part of the Shoulder Elbow Orthopaedic Group. I'd like to thank the organizers for the kind invitation to be part of this exciting meeting. The topic I'll be talking about is my worst case around the shoulder. I don't think there are any worst cases out there. They're just interesting cases that can be challenging and just require a bit more thinking and can be quite fun to do. All right. So without further ado, here's the case I'll be discussing today. He's a 46-year-old right-hand dominant manual worker. He's got no chronic medical problems of note. He's a non-smoker. He was involved in an accident when he was jaywalking and was hit by a bus traveling at 50 kilometers an hour. Now, full ATLS assessment was done in the ED, and these were the non-orthopedic injuries that he sustained. He had small intracranial hemorrhages, multiple undisplaced facial fractures, multiple rib fractures, you can see from the 1st to the 10th on the left side, and bilateral pulmonary contusions with a small left pneumothorax. Surprisingly, the neurosurgeon, the plastic surgeon, the cardiothoracic surgeon all said these injuries could be managed conservatively. So they said, okay, orthopod, he's all yours, manage the orthopedic injuries. So what are the orthopedic injuries he had? Well, these are his injuries. So you can see on the right side, he's got a closed mid-shaft right clavicle fracture. He's got a closed intra-articular distal radius fracture. On the left side, he's got a closed four-part fracture dislocation of the shoulder. And on the left elbow, he's got this open fracture. He's got the wound right over this area of the olecranon process fracture. You can see he's also got a lateral column fracture of the left humerus. So this is a summary of the orthopedic injuries that he has. And now I guess the issues to consider would be, okay, what are your concerns for the various injuries? With an open fracture, you'd worry about infection and wanting to debride that early, starting antibiotics and getting it treated definitively or stage-wise as soon as possible. With the proximal humerus fracture dislocation, you'd be worried about AVN, and anatomical reduction. Can you get it fixed? Does it need to be replaced? These are the considerations. The clavicle fracture, honestly, on its own, really isn't. Some of you may not even treat it, but in the setting of a polytrauma patient, for ease of rehab and earlier mobilization, you probably would treat all the injuries. And the distal radius fracture, since it's an intra-articular fracture of the dominant hand, you probably treat that as well. So what order of priority would you address these injuries? Would you try and do everything at the same time? Would you stage it? What takes precedence for you? I mean, for me, it would be the open fracture and the risk of infection, because the humerus fracture, as you can see, has got quite a long metaphyseal neck component. So the blood supply would still be attached. So there's a good chance he may not go into AVN, right? So I would definitely not jump in that straight away. I'd want to get advanced imaging for that before I tackle it. And then, so that's the further investigations. And what would your surgical plan be for each? Is there anything special you need on standby? Do you need bulk allografts, strut allografts, or just bone chips? Do you need any hemiarthroplasty sets on standby in case you can't fix the shoulder? These are the things you should be thinking about. So this is what I did. So on day one, what I did was I brought him theater straight away to address the open fracture. I did a thorough debridement of the wound, excisional debridement of the traumatized and necrotic tissue, and remove all the devitalized loose bits of bone that was around here. And so I stabilized the lateral condyle with 2 headless compression screws, and then I moved on to reduce the olecranon and fix it. As you can see over here, all the loose bone has been removed already. Now the temptation would be to put allograft, but usually in an open fracture, and that's the area of open wound, you wouldn't want to use allograft. If you do need bone graft, you probably should be using autograft, either from the iliac crest or elsewhere. In this case, because I felt the defect wasn't that large and it's a rich vascular metaphyseal region, I felt it could probably heal and come up on its own, which it did eventually. So you can see this is the final fixation on day one for the elbow. You can see there were some comminuted bits at the articular block which had to be removed. They were too small to be fixed. And you don't want to leave them floating around as well, so those got removed. And that's a little area of metaphyseal bone loss that's also been removed, but I didn't replace it with any synthetic substitutes. So the following day, when I said I tackled the two shoulder injuries, I got a CT scan, and that's the CT scan 3D reconstruction. Essentially, it's a 4-part shoulder fracture of the anterior dislocation. And tackling something like this, you want good exposure. You want a plan B in case you can't fix it. So that for me is a delta pectoral approach, good exposure, and then that's here, and then I get it all reduced. Then usually there's a bit of a metaphyseal void here, and if you want to avoid collapse of the humerus head after you fix it, what I'd like to do is put in a fibular strut graft. Now, some people put the strut graft vertically. I like to put it perpendicular to the the humerus articular cartilage, so it kind of acts like a buttress and a strut against it. I think either way is fine. And then you just fire in the screws, and it's all very nicely reduced. And that was it. We were done with the shoulder. I always have a hemiarthroplasty set on standby just in case. While I was doing this, my colleague was just doing the clavicle of the other side, and so that made things a lot easier. After I was done struggling with the shoulder, this side's done, so that's a huge relief for me. I like doing anterior plating of the clavicle. You've got nice long screws, more purchase, and it's a lot safer because you're in the lateral 2/3 of the clavicle. Your vascular and nervous structures at risk are all inferior. So if you're drilling anterior to posterior, it's generally safe. Also, anterior clavicle plating has got like 5 times lower chance of having to require secondary implant removal because of prominence. So the distal radius, that was interesting. So in my hospital, distal radius and hand fractures are managed by the hand surgeons. So this was actually treated by a colleague of mine. And for some reason, I can't remember what now, he wanted to wait for a week before he could address the distal radius fracture. It could be because he wanted the patient to recover from his multiple injuries and the surgical insults, or it could be that his schedule is really packed. But so he addressed the distal radius on day 8, and when he planned to do the standard volar plating, when he entered the carpus, there was pus. There was pus in the joint, so he decided to backtrack and said, no, we can't put any implants if there's pus in there. So he did a thorough debridement and washout, checked out all the tendons were viable, tried to reduce the fracture as best as possible, and put a back slab. But with nothing holding it, it still kind of falls out to place, and eventually it healed in that position. Okay. But despite that, by 6 weeks, the patient had recovered full range of movement. You can see of his elbow, of his shoulders, his grip strength of his dominant hand was back. His palmar and dorsiflexion of the wrist was also pretty good, actually. And he was very happy and he was back to work already. So this was a good outcome for him. So what are the learning points here? I guess in a polytrauma scenario, you want to prioritize. Are there any life-threatening injuries? It's always life before limb. And if so, then maybe you need to do some damage control orthopedics rather than doing early total care, right? And then if there are any limb-threatening injuries, you got to see what are they. Is it an open fracture? Is there any nerves or vessel injuries causing a limb at risk? And this need to be treated fairly urgently. There's a high risk of AVN, the most important thing is the anatomical reduction, not the timing of it. Whether you do it 6 hours or 12 hours, as long as there's a proper anatomical reduction, that's going to give you the best outcome. So I think if you're worried about AVN, make sure you've got adequate pre-op imaging and you've got the best pair of hands to treat the injury, because sometimes that's all that matters. So it's okay to delay it like a day or so. Have a definite plan beforehand. I think you need the necessary advanced imaging, you need the necessary equipment like your II support, the full trauma implant portfolio, bone graft, whether it's strut grafts or just bulks, like bone chips, KIV, the hemiarthroplasty sets for shoulder, and external fixators sometimes for those open fractures or for those unstable elbow fracture dislocations. You want everything on standby and you don't want to be calling for it in the middle of surgery. It's always good to have the necessary expertise available. So if it's an open fracture, you might want your plastic surgeon colleagues on hand so they can help you do a primary fix and flap if necessary, or they can tell you where to site your incisions so as not to screw up the eventual flap coverage. And if any microsurgical work is required, like nerve or vessel injury, to have your vascular surgeon or your microsurgeon around. I find it always helps to visualize your steps beforehand the positioning, the incision, the sequence of repairs, so that everything's a lot smoother when you're actually conducting it. So for this case in particular, I guess open elbow fracture was the first priority. You'd want to remove all the contaminated, devitalized tissue and bone. Titanium implants, some people feel perform better when there's risk of infection, so compared to stainless steel, so you can consider that if it's available to you, cost is not an option. And I wouldn't use any allograft or synthetic kind of substitutes if in an open fracture scenario, because you worry about infection. For the four-part fracture, proximal humerus fracture dislocation, ultimately, I think the age, the demands, and the severity of the injury determine the treatment plan. For younger patients, manual laborers, you always want to give them, try to retain the native humerus. Whereas nowadays for the elderly, 3-4-part fractures, you probably do a reverse. It's the standard of care. I think advanced imaging is essential for any of the para-articular fractures. I would always do a delta pec approach because, gives you the best access. And number two, in case you ever need a replacement, either intra or in future, you can use the same incision. And I always have like my fibular strut grafts and arthroplasty sets available on hand. Okay, so we come to the end of the talk. I'd be happy to take any questions now. That's the email address for my group, as well as my personal email there if you'd like to contact me as well. Thank you.